Hello and welcome back to another episode of the Vet Series. Today we have Afi with us and we are going to tell you everything about colic. We're going to tell you what to look out for, the signs, what colic is, what different types of colic there are, everything colic. We're going to talk colic. So, let's get on with it. Tell me what colic is.
So, colic in horses is basically encompasses any type of abdominal pain. So it isn't necessarily just that they've got a blockage, it could be anything. So horses that have liver pain can present with colic signs. So basically anything in the middle of the horse that's painful generally presents as colic signs.
Okay.
So when we talk about colic signs, it isn't just the routine ones that we know about and really commonly know. So like the pouring at your bed, the rolling, up, down, lip curling, etc. It can be more subtle signs. So we're also looking for things such as their appetite. Are they eating as much hay as normal? Have they turned their nose up at their hard feed? Is that normal for them? And just a reduction in that can show that they are slightly uncomfortable in whatever way, shape or form. It could be that the droppings that you've seen are fewer in quantity, the consistency might have changed, so they may have gone from having very formed faeces to very liquid faeces, or the other way around, so softer faeces to very, very hard, dry pellets. It can be that they're just sort of stood in the field, they're not really grazing, or they just look unsettled. So it doesn't necessarily have to be the pouring, the digging, the rolling, just any subtle sort of changes that you wouldn't normally expect for your horse that can sometimes indicate that they are in the early stages of
colicking. And is it only horses that, this is a question that you wanted me to ask the other day, that can be sick? They're the only animal that can't be sick, sorry.
So,
or is it
no, cattle can't be sick.
Okay.
That's technically a lie. You might want to take that out. So cattle can regurgitate and chew on their cud, but they can get what we call like a bloat, where they've got gas trapped in their abdomen and they can't get rid of it. So that is almost like a colic in a cow. I'm probably going to get loads of farm vets going, "You're talking rubbish." But yeah, horses can't be sick.
Yeah.
So the only way that we can relieve excess fluid build-up in a horse is for us to physically put a tube down there and get rid of it for them.
Yeah.
So that's why they tend to get so painful so quickly, because things tend to build up, and it's those horses that we're most worried about.
Yeah. And what are the different types of colic?
So all different sorts of colic. There's many, many types. So when we talk about colic related to the GI tract, we could be talking about spasmodic. So that is where your GI tract and your guts are basically squeezing and trying to digest everything a bit too quick. So it's a bit like, I try to describe it to my clients, it's a bit like you've had a dodgy curry.
Okay.
And your tummy is basically turning over really, really quickly. You've got loads of sort of like contracting type pain. And basically the only way that these guys can show that that's happening is by showing us all their normal colic signs.
Yeah.
You've then got things like displacement, so that's portions of gut which have put themselves in the wrong place. The horse's gut is designed really badly in that it isn't really secured in any way. It is pretty much free floating, and there's lots of little areas where it can swing around, flop into places it shouldn't be, and then that's what we call a displacement. That's what we usually detect on rectal examination, so when we go in rectally and feel where everything is. Then we've got things such as impactions, which can be an impaction in two different places within the abdomen, within the gut, and you can also get a gastric impaction, which is in the stomach. So if you've got reduced emptying of the stomach, it can feel full of grass, feed, hay, and become stuck. So that's a gastric impaction. Again, presents as abdominal pain, so any of your colic signs, but on all your other clinical examinations, everything seems really normal. And then other impactions, so you've got pelvic flexure, so coming into the pelvis, your gut's about this thick, and then it narrows right down, and then it opens up again on the other side. So you've essentially got a bottleneck. So if you get a huge amount of long fibre coming down into that portion, it can get stuck and not come through. Again, that's something we palpate on rectal. There's also a narrowing at the opposite end of the abdomen, up by your diaphragm. So you can get a diaphragmatic impaction. Those we can't palpate. Obviously our arms are only so long, and if I were to stand at Affy's bottom and her diaphragm is here, you can imagine I'm never going to feel far enough to be able to feel that. So that's sort of a diagnosis of exclusion, really. With impactions and things where we're worried there's a blockage, we usually pass a tube up the nose to make sure that there isn't any fluid backing up, because they can't be sick. They're the most common ones that we see. There's also incidences where older horses can have strangulating lipomas, so they're little fatty masses on a stalk that can wrap around the gut and cause an occlusion, and basically cause the gut to die off and stop the blood flow. They tend to be quite dramatic in pain. Having blood cut off is quite painful for horses.
And how often do you think that horses that are presenting colic signs where you've got to go out, not that it because sometimes, like Affy's colic, and we've been able to treat it at home without a vet coming out, just by speaking to you guys on the phone. So when you do go out, how often do they have to go for surgery, or at least go to the vet?
There aren't that many, to be honest. It's not very frequent. I suppose it's one of those things that as a horse owner, you're like, oh crikey, if a horse has colic, it's going to be a hospital job. It isn't always, and I would say probably less than 20% of what we see ends up going. I would say it's probably more like 90% we can treat at home. There are few and far between that get to that stage. I mean, the earlier that we get to you to see a horse, if it starts to show early colic signs, the earlier we get to you, the more likely it is that we can control something, or catch it in its early stages, especially with displacements. Sometimes we can manage those at home, and with early medical treatment. I suppose it's always, if we're ever concerned, obviously there's lots of things within our clinical exam that's going to tell us where we're heading, but normally we'll start a telephone conversation asking all the relevant questions. What are they doing? How are they doing it? To gauge an idea of how painful they are. If I were to speak to somebody on the phone and they were telling me the horse is very painful, I might already said to them, right, okay, make sure your lorry's ready to go.
Just in case,
I've got a suspicion from what you're telling me. It may not be, but if you're ready to go, at least we can send you straight away. Or if I go and see something and I'm like sitting on the fence, let's see what they do in the next hour, I'll always have them sort of ready with transport, that if things get worse, people are ready to go. But I think it's one of those things that, yes, it's a scary thing and we all worry about it, but actually it happens less frequently than probably
people think.
I think it's, you only ever hear really of the ones that, or you hear the worst stories from people. You don't necessarily hear about all the ones that have had a bit of a grumble and had a bit of medication and been fine.
And then, is it true, this might be an old wives' tale, that when they go for surgery, they are then more likely to colic than any other horse for the rest of their life?
So whenever we go in surgically, we've obviously gone into what should be a closed cavity that shouldn't have human hands in there fiddling around. When you touch GI tract in a live animal, you damage the surface of the gut very slightly every time. It doesn't matter how gentle you are, you will cause some damage. The gut's way of fixing itself is to stick to another piece of gut. So the more you have to handle that piece of gut, the more likely it is going to stick to another. So what happens post-surgery is you end up with adhesions, so bits of gut stuck to other bits of gut, which make them less mobile. So then if you end up in a colic situation, impaction situation, where things need to move a bit more, it's a bit gassy distended, if you've got two pieces of gut that are stuck together and they can't move, that adhesion's going to be painful. So yes, they are more likely to show colic signs. Whether that is a true colic that needs severe intervention, or is that mild abdominal pain because of adhesions that are there previously, that is sort of the distinction that you have to make between the two. That's the main reason why they are more likely to colic. Obviously, sometimes when they go for surgery, they have resections, so pieces of gut that are taken out. So you have one end, you take out this middle portion, you suture them back together. In those cases, those ones, obviously, they are going to have an adhesion because you've got a surgical join, and then the gut's going to stick around it to stop it from leaking. It's the only way the gut can stop from leaking. So when you have those, obviously, you've got a shortened piece of intestine, so it isn't going to be quite as functional as it once was, and also you're going to have the adhesions associated with that. So that's things to bear in mind.
Yeah. Right, do you now want to show us kind of what you'd look out for and then what you would do when you were coming, say my pony's colicking?
Yeah, so
also, can I just comment that she's not sedated? She is just this lovely at the moment.
she's
I
just
keep
really
looking
chill.
at her eyes and she's like this, and like, they're going to think we've sedated her for the video. I promise we haven't.
So if Affy was colicking, so
Yeah.
if you phoned me and said, right, horse is colicking, so we're going to pretend that Affy is, first thing I would do when I arrive is like, what's she been doing? What have you been doing with her prior to my arrival? So quite often I'll say to clients, if they're happy to walk around the arena, walk them around an arena so that you're getting them moving. Sometimes that can just get some gas out. So if they're just gassy, that helps get things moving. It also keeps them distracted, so stops them, if they are rolling and things, stops them throwing themselves around in the stable. But equally, if they want to roll in the arena, you're in a big open space. So I'll always sort of check in, see what the history is, what changes we've had, what clinical signs she's been showing us, and then we do the physical bit. So if I can swap sides with you,
Yeah.
Han.
Do you want rug it off? Are you happy rug it off?
Yeah, let's whiz a rug off. The first thing I do is I check their colour. So if there's something significant going on in there, so we've got a torsion or something where the blood flow is affected in the stomach, they can go septic, which can change the colour of their mucous membranes, which is their gum colour. So the first thing I'll always do is look at their gum colour. Is it pink? Is it moist? So is it wet, or is she tacky? Does she feel like she's dehydrated or not been drinking or anything for a while? The other thing that I look at is the capillary refill time. So the little blood vessels in the gums, I basically, good girl, I know it's weird, isn't it, sweetheart? I know,
Good girl.
hard lady. So basically I push on it and then take my finger off and see how long it takes for the colour to come back. Less than 2 seconds is normal. You can have increased capillary refill time when you've got an increased heart rate, and you can have a sluggish if the blood's going elsewhere.
Okay.
I will then check for her jugular fill. So what is her blood flow like? Is she filling in the expected amount of time? So can I raise this jugular vein in the rate that I would expect it? If I've got blood going elsewhere, for instance, it's all making its way to the GI tract because there's something wrong, sometimes you can have a sluggish jugular fill. Also gives me a little bit of an idea on hydration status. The next thing I do is check for a skin tent. So I basically pinch the skin on the neck, pull it away and see whether it comes straight back onto the neck or not. So until you get about 10% dehydration, that won't happen. So it's quite a crude test, but in sort of really bad horses or horses that are severely affected with colic, then that's something that we will be monitoring for. Next thing I'll be doing is listening for heart rate. So heart rate should be less than 40 at all times in a healthy horse. You can have horses that are showing colic signs whose heart rate is below 40. But if I've got a horse that is 16 hands, very fit event horse, for example, if their heart rate's 40, that horse is probably painful.
Yeah.
Whereas if I've got a Shetland who's got a heart rate of 40, that's probably normal for them because they're small and their heart rates are faster than the bigger horses. So obviously Affy's heart rate is totally normal now. But I'm also listening for murmurs. So horses that are physiologically stressed can sometimes develop what we call a flow murmur, which then tells me how stressed the body is. I'll also listen to the rest rate just to make sure that there isn't anything else going on in this portion of the body, because horses, they don't have a lot of ways to elicit pain and show us that. So if I have got anything else going on, I'm just checking and making sure I'm not missing something that I should be looking out for. We will then be listening to gut sounds, which we listen to in multiple different places. So you've got what we call quadrants within the gut. So you've got 1, 2, 3 and 4. So we've got a dorsal and what we call a ventral. So we listen to the top portion of the gut in what we call the paralumbar fossa. Here.
And as an owner, we before you come, we can be listening with our ear, can't you?
And
sometimes you can hear.
You can hear them rumbling and grumbling. So if that you can hear loads and loads of gut sounds, the chances are they're more spasmodic and gassy.
Okay.
The quieter the gut sounds are, the more we start to get concerned, because why is that gut slowing down?
Yeah.
If the gut's speeding up normally, it's a case of they've eaten something dodgy or you know, horses are designed really badly. Sometimes they just do weird stuff, as we all know. But as gut sounds get quieter, that's what we start to worry about. So we'll be listening in this dorsal quadrant, and then we'll come down and start to listen a little bit more ventrally. I will occasionally as well listen right on the bottom of their abdomen, so that I can have a listen to the very, very bottom gut segment, and the intestines that are sitting right on the bottom. So I'll do that, and then basically I repeat what I've done on the opposite side, in that I don't repeat like my jugular exam and skin tent, but I will listen to the heart again on this side. I'll then listen to my lung fields, and then I'll be listening into my dorsal and ventral quadrants of my GI tract and getting an idea of what's going on. On this side of the horse, you've got a big fermentation chamber called your cecum, which sits here. It tends to be quite a gassy creature, but sometimes if you've got a very gassy cecum, you can hear it pinging, and it sounds a bit like a balloon. Like if you were to flick a balloon, you get like a really audible ping, and that can sometimes tell me that I've got a really gassy cecum in there. My next step will be to take their temperature, make sure their temperature is normal. Horses that have got really high temperatures, they will go off their food and be a bit dull and quiet, and occasionally be a bit sort of like kick your abdomen and things. So as a routine, I always make sure the temperature's normal, so that I'm not potentially thinking this horse has got colic and something significant going on, when actually it's just got a stonking temperature.
And again, that's another thing that as owners we can do, can't we? Like,
yeah,
I've got
absolutely. Making sure that you've got a digital thermometer
and then
is
just
really
checking
useful.
them,
And or equally, just knowing what your horse's normal temperature is really useful. So if I came out and I checked her temperature and she was 38.5, which is very top end of normal, if you said to me, no, this horse's temperature is normally 37, I'd be like, okay, something's starting to occur. So that's like my normal starting place for a colic exam. Depending on what I find, depends on where I go next. So if I've got a horse that's truly spasmodic, then, and the guts are turning over really, really fast, then I usually give them Phenidine and Buscopan, so medications. So Phenidine being pain relief, Buscopan being a anti-spasmodic, so just like Buscopan in humans, to calm everything down and stop it cramping. And then I will quite often watch and see what they do. Gold standard is to rectal and pass a nasogastric tube on everything. However, in reality, finance also comes into play a little bit. So, you know, these things do cost money, and sometimes we've got to be sensible about where we're spending our money and what we're doing. And some horses you listen to and experience helps you with this. You go, yeah, that's a spasmodic colic all day long. This is what I'm doing. Other times you can be sitting on the fence and going, actually, I'm not walking away from this horse without doing the full works. Yeah. Because you can quite easily miss something. So every horse with colic of mine will normally get Phenidine and Buscopan. Some vets won't give Phenidine because they feel that it can mask a surgical colic. Okay. And again, it's very variable as to what your vet will give. Some will just give bute, because bute isn't as good at alleviating abdominal pain. So if they are going to show further colic signs, they show it better with bute. But my personal preference is to give them Phenidine, and if I'm concerned, I just won't give them such a big dose. Yeah, okay. I'll just taper my dosing slightly. So every horse will get that. And then from there, my next step would be to do a rectal examination. So I didn't get any out actually, my rectal gloves. No, you didn't? No, I should have brought some rectal gloves out. Don my rectal gloves. They're really long. Really long gloves, keep me nice and clean. And I will be basically putting my hand up a bottom and having a feel of what we've got going on. We could then put our... Please don't be annoying. We could then put our video in of what it looks like on the inside and what I'm feeling for. So some of you may have wondered what on earth we're doing when we're doing a rectal examination. So we have used this lovely video, which is from the Glass Horse. This is a program we use as vet students to sort of visualise what we're going to be looking at. So you can see a person with a hand. So this is going in rectally. The hand's gone in and it's feeling around the pelvic brim. So this is the entrance into the pelvis where our abdominal contents is. So the hand's sweeping. We then come further forward and we start to feel for our intestines. So you've got colon here underneath us, and what we can visualise is the pelvic flexure. This is the site of where we commonly will feel impactions. Then the hand is reaching forward to feel whether everything is as it should be. Does that portion of the colon flow forward nicely? We then turn our hand towards the outside of the body wall. So this is now facing palm out towards the horse's ribs. And we're going to feel for the spleen. That is the purple structure. And then the little oval shaped structure is your left kidney. So we're feeling that those are there and that we've not got any portions of intestine that are in between those structures. So between the kidney and the spleen, the nephrosplenic space, or between the spleen and the body wall. The hand's then coming round to the right to feel the cecum. Now this can be distended with gas. You can also start to feel displacements in this area. So you can feel the right dorsal colon coming across, and causing a displacement. So the hand's carrying on feeling that cecum and making sure that it's all where it should be.
So yeah, if I'm rectaling and I feel something, I will often be talking the owners through what I'm feeling. So I have like a systemic, like every vet does it slightly different. So I go in and I have a general sort of feel round. Can I get in is the first question. So if I've got a displacement, sometimes I can't even get in. So that's sort of like my first test. And then if I'm in, I'm then feeling for gassy distension anywhere. Have I got the bladder underneath me? Is the bladder full? Have I got a pelvic flexure impaction? So that's the first thing you get to, where the gut comes down to the pelvis. You just pop over the pelvis and in. And then you start to sort of make your way in a bit deeper to feel for other structures. Have I got poo coming through? Have I got little fecal balls I can feel? Sometimes in the smaller ponies like Affy, you can feel your spleen. So if your spleen's not against the body wall, that can indicate that I've got a displacement. It starts to get quite complex when you go into rectal exams, but we can try and put some of those videos on. So if the rectal findings tell me something like I've got an impaction, I know that I need to basically give this horse diarrhea to get rid of it. If I haven't got an impaction, I've just got something gassy, then often just pain relief and Buscopan is enough to relax everything for the gas to make its way through, just like Buscopan does in humans. If I have a displacement, there's one type of displacement, which is a right dorsal, that I can sometimes medically manage at home with fluids and lunging. However, if I've got any concern that something is going where it shouldn't be and I'm not happy, I will be advising that you get on a box and go in for referral to a hospital where you've got surgeons on hand. If things go south very quickly, you're in the right place, rather than me leaving you at home and then going, should have sent that. So
it can all change very quickly, can't it?
Yeah, it can, absolutely. So some of the things that I do can speed up the progression of clinical signs. So, for example, if I hadn't found anything rectally in Affy, my next step would potentially be to pass a nasogastric tube, especially if I think her heart rate's higher than I would expect it. So basically, let me grab my bucket of goodies, my little colic bucket with nothing in it that's edible, Aff.
Are you sure?
Yeah. So if I thought that I needed to, I would be passing a nasogastric tube, which is a very, very long, flexible tube. This is a really nice soft one. This tube has to pass up her nose. It then goes down into the back of her throat, and then I've got to get her to swallow it and go all the way down into her stomach. So, you know, it's very long for a very good reason. If you hold that end for me, Han, your stomach is down here, but actually by the time you've gone up nose, into her throat, down her esophagus, which then comes down on the opposite side, may I add, and then into stomach, you know, I need quite a lot of tube. Affy's smaller, but in a 500 kilo horse, I will get that sort of deep in the horse, tube-wise. So we pass this one down. As we're going, I'm sucking on one end to see whether I get stuff back. So
is that not a bit like scary?
Yes, it's a bit like reflux roulette. is what we know it as.
Is it going to end in my mouth?
Yeah, exactly that. It does. It does sometimes. It's just what it is. We have a really glamorous job. So I'm sucking on this end. If I happen to accidentally pass this into the airway, when I suck back, I get air out of their lungs. So I know I'm in the wrong hole. If I suck back on this and I get what we call negative pressure, so if I don't know if I can do it. So you basically
suck back and it like, you can't suck anything.
Yes, I know
it's
what you
like
mean.
if you suck on a straw with your finger over the end, you can't get any air through. If that happens, I know I'm in the right place. So basically, we then keep passing it all the way down into the stomach. Once you're in the stomach, you get gas back. So you then know you've popped into the stomach in the right place because acid produces stomach and your digestion, etc. So then once I'm in, first job is I sniff it.
Lovely job.
Really lovely job. If you've got stuff in there that's been sat there a really long time, it smells vile. If I've got reflux, which is basically digested material coming back from the gut up into the stomach, it smells vile. So that's our first test. I don't taste it, I promise. So if I have got a blockage and I've got fluid building up in the stomach, I've got to siphon it out. So essentially I then suck on my tube until it gets to the point that gravity will help it flow out. We usually measure reflux in litres. So if you've got anything more than about a litre of reflux back, you've got a blockage that you probably want to do something about. If you've got about a litre or less, then I'm happy to put fluid in the front end. Mm-hmm. Sometimes by putting fluid in the front end, you will speed up the progression of clinical signs, and it can sometimes tell you that you need to go to surgery sooner rather than later, because I've put more liquid in and made them uncomfortable. Mm-hmm. If I put liquid in and they don't become uncomfortable, it's going somewhere. Yeah. If it's not going anywhere, they will continue showing colic signs despite pain relief normally. So if I get no reflux, quite happily put fluid in, and in case of an impaction, we'll be putting quite a lot of fluid in. If I do get reflux, I say, you're getting on a lorry and we're going, because I'm concerned there's a significant blockage there. If we are looking at treating impactions, we then get out some of my trusty friends, and this is where you have to have glamorous assistants when you're out and about, so we tend to drag in additional people other than just owners. So when we have impactions, there's a couple of things that we like to put in our water to go in. So here I've got a tub of magnesium sulfate, essentially Epsom salts, and we use these select sachets of electrolytes. So if you've got an impaction, we're often going to be starving the horse for a period of time. So that just makes sure that we've got all the sugars and salts that we need to keep functioning. So in my bucket, I will make up my solution of varying volumes depending on size of horse. And then I will be passing my jug to my glamorous assistant, and she will be funneling into my tube. So while I'm in the horse,
Oh, I see, yeah.
like this,
Oh, then be
I will have my funnel on the top. Han would then be pouring my fluid in. I would then be standing here with my tube in the air so gravity can pull my water in. And then we keep going until we finish our bucket. The idea of the salts is that you want to draw fluid into the GI tract. So by putting salt in there, osmosis, back to GCSE biology. It's going to get really complex now.
Okay. Sorry, guys, about this.
Like when you add salt to your veggie.
Yeah, exactly. So, when you add salt in and you make that concentration of salt greater in the gut, the water from the rest of the body gets pulled in to help break down that impaction. Years ago, we used to use propylene glycol, which now we know doesn't work.
Okay.
So the idea of that was they thought that it broke down impactions. What it actually does is it just makes its way around the edges and does nothing.
Yeah.
And if you accidentally got it in the wrong hole, so you got it in your lungs, it's not very nice for the horse at all.
Yeah.
So we don't really use that anymore. We just use our salts and water. And then that normally is sort of everything I can do for a colic in the first instance. And then it's a case of monitoring them and seeing what they do, plus or minus starving them overnight if I need to.
Stop.
Being really helpful. And then making an individual plan for every horse dependent on what I found and what we need to do for that individual. And it changes dependent on your situation, your stabling situation. Are they at grass? Are they in? Have you got a stable? Have you not got a stable? It is all very variable. And with ambulatory practice, it has to be, because not everybody has got the perfect setup.
Yeah. So with impaction colic,
Yeah.
if it was really bad, would you not do that? Would you just send straight to surgery?
So most impactions you can manage, especially like pelvic flexure, where you can palpate them and you know whether they're moving or not. you can manage them at home. Some of them, if I've given them a good 12 to 24 hours and I've had no feces, sometimes you have to think about IV fluids and hydrating them in other ways other than just putting fluid up the nose and into the stomach. What can happen if you put too much, I say too much, but lots of litres in, is that the fluid then pools at the lowest portion of the gut and pulls pieces of gut down to sit very heavy at the bottom. And then there is only a finite limit of fluid that you can put in the front end before you end up with that, and then it's not doing you any favours. And then you have to start thinking about how else can I hydrate this horse to try and encourage this to move. And then we're thinking of IV fluids and more intensive management in the hospital situation. I haven't yet in my ambulatory career had to send any of my impactions in.
Okay.
I have managed them in the field. I think the longest one that I had that took to pass was 72 hours. But that client didn't have the funds to be able to go for referral. So I think it's always a really good place to start with your vet is to be very honest with, is the horse insured? Is referral an option? If it's not an option, can we manage it at home? And occasionally, unfortunately, there are certain cases that referral isn't an option and we have to do the kindest thing by the horse.
Yeah.
So the other type of colic that we haven't spoken about is sand colic.
Yes.
So some soil is really sandy. So depending on whether you're a lucky person who's got very dry paddocks. So if you've got very, very dry paddocks, the likelihood is that you've got well-draining soil, which often has a high sand content. If you've got pretty boggy wet paddocks, you're probably on clay, so you've got less of a sand risk. Sand, inherently, because horses graze, does get ingested. They will end up eating a portion of it, and it can basically form a sediment in the bottom of the intestines, and you can end up with sand colic. So these horses tend to show you quite mild, personally, I tend to find they're quite mild colic signs. You sort of look at them, nothing's very specific in your clinical examination, you're not going, the heart rate's really high, gut sounds aren't really absent or elevated, rectal temperature's usually normal, but they're uncomfortable, but there's nothing really giving you any idea as to why. Those ones are ones that I tend to rectal as a precaution. And when you go in and you rectal them and you're fishing out the poo that's in the rectum, you quite often feel that it's gritty. So you'll have your hand in there and you're like, you can just sort of rub it between your fingers, like you're on the beach and you pick up a few grains of sand and you can sort of roll them between your fingers. You can just feel the sand there and you're like, oh, a bit suspicious. So obviously I'll have emptied my rectum and put my poo in a pile in the stable, and then when I finished, and often I find nothing exciting, what I will do is I'll do a fecal sand test. Now this is a test that you as owners can do at home, especially if you're on sandy soil, just to see what your sand risk is.
There's also supplements you can put them on to...
We'll get there.
Okay, sorry.
Because I'll go and get some.
So I had a pony, I used to be on sandy soil and I had a pony that had impaction colic, which is why, sand impaction, which is why I know all of this.
Right, do you want to do...
Yeah.
Should we come out to your wheelbarrow?
Yeah, come on then. I'm going to move this out because I know what Affy's like.
I'm just going to play with it, isn't she?
She'll pick it all up.
Here is a glove, so you can pick up some poo. So then here is one of my trusty rectal gloves, which is what I tend to use when I'm out and about because it's all I've got.
Yeah.
But you can use a sandwich bag or similar.
Okay.
So what you're going to do is find me a couple of nuggets of poo.
Yeah, ideally without the straw on.
Yeah, pop them in my glove. Right.
I nearly used my other hand then. I mean, we
all
do it. So.
I did only give you one glove, just to, half that.
Half that?
Yeah, it's quite a large one.
Okay.
Right, pop that in. Then what you're going to do, take your pooey glove off. Then I want you to fill this up with water to sort of so the hand bit's full.
Cold?
Doesn't matter.
Yeah.
Yeah, a little bit more. That's great. And then what you're going to do is hold the top of the glove, squidge the bits of water out, and then what I want you to do is basically massage that down so all the poo is broken up, like you've got no solid bits of poo left. And if you just give it like a smush around, it'll do its thing. So the idea of this is sand is heavy, sand will sink to the bottom, and all your fibre, so the bits of grass that are chewed up, will form like a layer. A bit like when we'll talk about ulcers, you end up with a fibre layer that floats on top of your acid. It does a similar sort of thing, making a little raft.
There's a big bit that I can't get,
Which
but
bit?
I also can't. It's there. There's a big poo. You feel it?
Yeah, got it.
Right then.
Right, and then what I tend to do is you tie a knot in it, just like that, and then what we'll do is we're going to hang it on a hook somewhere outside Affy's stable, and we just leave it.
Okay.
So then we're going to leave that for a few minutes to see whether anything settles. So this can be done at any time. So if I've got, I'll wait for you to come back.
Sorry.
So here I have some psyllium husk. So
Yes.
this is what we talk about feeding horses that have sand colic or on sandy soil. So this is just I basically get myself a bag that I keep in my car, so that if I have a sand colic, I will basically tube them like we do in any impaction, but I tube them with this psyllium, so I give them a bulk dose first.
Okay.
So this is then just it's not branded or anything. However, there's lots of psyllium-based products on the market for
loads
feeding to
different, isn't there? Yeah.
horses. Some of them are like, it's sort of like usually have sand in the name somewhere along the
Yeah.
line.
Or like Sandex, I think is a good
Yeah,
one. Yeah.
and there's all sorts of like pellets and all sorts of
Yeah.
versions of it. But the idea is the husk, it does swell a little bit, a bit like chia seeds.
Okay.
It sort of swells in the gut and acts like a sweeper. So it picks up the sand and takes it with it to sort of wash out any sand that's building up within there. In times of crisis, so you have had a sand colic, we feed an elevated dose. I always say whatever product we end up using, because every vet is different, every person gets different products, feed as per the feeding recommendations on the, or if you're concerned, ask your vet, because your
Yeah.
vet will also advise you, you know, you can feed 1 gram per kilo of body weight per day, but that's obviously quite a large volume. We probably won't need that much, but if you are ever concerned or you think this isn't doing the trick, we can advise you as to how much to feed. So feed as per feeding recommendations unless advised otherwise. We normally do, in horses that are prone to getting sand colic or we know are on sandy pasture, we normally feed an elevated dose for 7 days of a month and then feed a maintenance dose for the rest. So we're doing a week of washout and then the rest of the month as maintenance. And then as owners, I've got owners that will do a sand test for me every month. Just at home, just to check that they're on top of keeping their sand burden at bay. So my most recent sand colic, they are due to do a sand test for me this week, and then they'll send me what they found, and then we make a plan as to whether we need to do another elevated dose sooner than we would do once a month to get them back to normal, so like an adequate level, or whether we need to do anything different. We'll have a look at this and see whether it's done anything. I know it hasn't been there too long. So, don't know if you can see in there, you've got a water layer and then you've got a fibre layer.
It's your poo Aff.
Affy's having a good old sniff at it too. And then what we do is we start to feel at the bottom of the fingers for if there's anything gritty or sandy. Now, I don't think your soil here is particularly sandy,
it's
so
not.
we're not expecting to see a lot. I mean, if I'm super fussy, there's the odd little grain in there that you can feel, but normally if you've got a horse that is a true sand colic, you will end up with a line that demarcates sand in there.
Okay.
So the last one I did, basically every finger was full of sand.
Yeah, okay.
It was that sandy. But this is a really easy at-home test to do. If you use a sandwich bag, just tilt it so that the corner is the lowest point, so you're pulling the sand down into the bottom corner.
Okay.
But yeah, anyone can do that at home.
Yeah. Thanks. Just pop that back up there.
Yeah.
That'll probably stay there now for life.
Save that for later.
Probably won't move that, will I?
So one of the clinical signs that I've not mentioned
Yeah.
so far is that some horses will show abdominal pain by making or standing in the posture that they would to have a wee.
Okay.
So posturing to urinate, gelding stretching out, front legs out in front, hind legs out behind, looking like they're straining to urinate. And I will sometimes have clients say, oh, my horse is really struggling to go for a wee, like, have they got a urinary tract infection? I'm normally like, that's a colic sign normally. And quite often it can be that they've got pain in the front portion of their abdomen, so around their stomach, occasionally we see it with ulcers as well, that sort of posturing to try and alleviate pressure. So if your horse is doing that, I would definitely recommend phoning your vet, discussing through the signs that you're seeing, and quite often we'll want to have a look at them to make sure we're not missing something more significant. And I think that's a really important thing to say, that if you are ever concerned that your horse isn't right, showing any mild colic signs, we're at the end of the phone. We'd much rather phone you and say, no, that's nothing to worry about, than something be left and it be a major problem. So if you're ever concerned, I can't reiterate enough that you must phone your vet and have a chat. I'd like to think that everyone's vets are nice and friendly and you can pick the phone up to them, but that's what we're here for at the end of the day. And I suppose the only other thing that leads me on to is remembering that we need to have explicit permission from you to attend. So
Which I didn't know this. I mean, it's common sense, but I didn't know it.
So if, for instance, you're on holiday and we can't get hold of you, there needs to be somebody else that can give permission for us to treat your horse in your absence. We can't not attend, but we do have some limits upon what we can do that is dictated to us by the Royal College. So there's certain things we have to do, so provide pain relief, but there's certain things that we wouldn't be able to do without your permission. So everybody should make sure that they've either got it written in their livery contracts that in your absence, your livery yard owner has explicit permission to request the vet and authorised treatment, even if that includes euthanasia, or you have phoned your vet specifically, given a dedicated name or couple of names, that in the event that you're uncontactable, that they can authorise treatment for you. One thing that we haven't discussed is worming. So high worm burdens, and particularly encysted redworm, can be a cause of colic symptoms. So we will discuss worming again in another video. I think that's part of your plan.
Yeah.
So we'll cover sort of worming and those types of things, and sort of if you've got encysted redworm, what then happens to lead to colic signs. But it's just important to say that parasites can be a cause of colic as well, but like we say, we'll go into that in a bit more detail again. The other thing to bear in mind is that should your horse ever need referral, having a plan for what you're going to do with regards to transport. So some people obviously have their own trailers and lorries. If you haven't, have you got a list of transporters you know you can call? And also having a think through, because surgery isn't something that everybody wants to do. When you're in that moment, in an emergency situation where I'm saying to you, right, this is a surgical colic, are you going to a hospital, like, do you want to do this? Saying no is a perfectly valid option. Not everybody wants to go for surgery, because what the horse is going to be able to do at the end of it may not be what they were doing beforehand. So for some people, surgery is not an option.
And also for the horse, like I would I've put horse through surgery before, and if I could, I would put her through surgery. But I don't think she'd cope with it.
Yeah,
with
so
the surgery and the aftercare.
Yeah, you've got to think about your rehab as well. So having a think about this ahead of time, so you know, not that it's ever going to happen potentially, but so you've got a plan that if it does happen to you, am I going to go down the surgical route? Will my horse cope with the aftercare of surgery? If you've already thought those things through, when you're in that moment, which is a very stressful moment, you've already got a plan and you know what your decisions are, you then can't be swayed by the emotions of the event in front of you.
Yeah, no, definitely, that's very important to think. I think that is it on colic. I think this is probably going to be a very long video, but I think very informative, which is obviously what we all want. Thank you so much, and we will see you for the next video.